welcome Dr. Gauri Shankar sir. He's a pediatric pulmonologist of 33 years experience. He's the emeritus editor of Indian Journal of Practical Pediatrics, associate editor into pediatric textbooks 12. He's the head of the pediatrics in Mehta Multi-Speciality Hospital. Over to you, sir. We welcome panelists.
Okay, I'll make your job easy. I'll welcome my panelists.
Thank you,
Dr.
sir.
Gopal Subramaniam, Dr. Kumaravel, Dr. Jagdish Kumar. Thank you, KONGU PEDICON, for giving me an opportunity. I know those who are gathered here are really interested in targeted versus empirical therapy in pneumonia. Thanks to you for having waited for us to finish the GB, and like now we'll go into this. I'm going to have only 2 cases, but before that, certain things will just be very clear. Community acquired pneumonia is clinically defined as fever, cough, lower respiratory tract signs. That means an infection which is occurred outside a hospital setting. Most common CAP pathogens are virus, but among the most common bacterial, it is Streptococcus pneumoniae. Because we are using indirect sample for testing, that means we are going to limit the identification of the causative pathogens. But many a times we do have viral bacterial co-infection. And we know we have reduced our practice by giving vaccination like HIV and strep pneumoniae. But we need to know that there is an increase in antibiotic resistant strains, especially MRSA and macrolide resistant Mycoplasma pneumoniae. And even in US, after the guidelines have published, they have done a reassessment after 10 years. Once the guidelines were published, whether there is any change in the prescription practice, yes, there is an increase in the prescription of aminopenicillin, that's amoxicillin, but the rates of diagnostic testing did not change materially. Now we have this scenario, 7-year-old child, girl child, who had a background, recurrent episodes of cough and cold from 4 years of age. Now presents with cough, cold and fever, but no chills for the past 6 days. Initially treated as OP, we don't know about the antibiotics. She developed, on the day of presentation to this panel, she developed chest pain in the right side in the early morning. That time we are not available. So they went to a 24-hour clinic and they had some symptom improvement with a parenteral medication and liquid medication. The child had some investigations done. On examination at the time of arrival, we know that she was obese and no pickle, no icterus, cyanosis clubbing, adenopathy, edema, no external markers for TB, respiratory system. We had decreased breath sound in the right lower hemithorax, right mammary, axilla and infrascapular area. All the others were normal. Now is Dr. Gopal. What is going on in this child?
Thank you, Team KONGU PEDICON, for giving us this opportunity to be here among the elect panelists. With this clinical scenario, we have a child who's 7 years old, who's obese, who's having recurrent respiratory infection, every time gets better with symptomatic treatment. This time, she's presented with a fever and a chest pain. So, with this clinical scenario, my first diagnosis will be a pneumonia, probably with a pleural involvement that causing a pleuritic pain, or we need to look into the radiological aspects also to rule out an effusion.
Very good, Dr. Gopal. Like whenever you have a chest pain in a child who has got a cough and cold, a pleural involvement and effusion, very good. Dr. Kumaravel, any relevant information which I had missed in this present illness history?
Yes, sir. We would like to specifically ask for any history of inhaler usage, any history of foreign body aspiration in the past few days, and any history of contact with the tuberculosis or past history of COVID. And since the child is on also having obesity, child child is having. So those sort of histories will be more helpful in analyzing.
Jagdish, I know, like in your busy practice, you may not have that much time to get history, but anything relevant in the past history which you would like to know?
Yes, sir. First, I should thank the IAP Tamil Nadu for giving the opportunity today. So regarding this past history, sir, since a child suffering from recurrent cough cold for the past 4 years, I would like to know whether child has been given any nebulization in the recent past, for the past 4 years, to rule out any bronchial asthma, and then any positive any admissions for the same, whether the current antibiotics, correct dose and correct duration has been given or not. Since the child suffering from for the past 4 years, I would like to know the immunization history, particularly the flu vaccine and H influenza vaccine and pneumococcal vaccine in the child. And then I want to rule out any source of infection like any chronic sinusitis, any adenoid hypertrophy in the child, by asking for persistent nasal discharge or headache like that. And any history of any exanthematous illness like measles in the past, I would like to know, sir.
So I had missed all these. They have found out, yes, these are the history which I had missed out when I had examined this child. Okay. Now, this is the X-ray what she had brought on the day of admission. So Dr. Gopal, your views.
They have brought out with the X-ray, but we need to have an investigation which should be appropriate and adequate to come to clinch the diagnosis, to find out the etiological agent. So basically we'll go with the basic blood test, which includes complete blood counts, the differentials, the markers like CRP and ESR, culture, even though it may not be positive, it may not look lucrative all the time, but I'll definitely go for culture, because in a febrile child with pneumonia, we always want to get an etiological diagnosis. Then we'll go for nasopharyngeal swab, cultures, manto. Probably I'll go for the mycoplasma serology, viral markers. Again, I need to look into the other infections, rule out other infections also.
Right, very good. You have given a comprehensive list. Even though we know that blood culture yield may not be very less, sometimes if you are going to have a strep pneumonia in culture, that is going to be of use, right? So these are the investigations which I had ordered, like Dr. Kumaravel. Can you interpret this lab results?
As we can see, the investigations, there is total count is elevated, leukocytosis is there, platelet count is normal, CRP is elevated, ESR is also elevated, renal function tests and electrolytes seems to be normal, and LFT, RBS also seems to be normal, and in the smear you can see normocytic, normochromic, neutrophilic leukocytosis and mild thrombocytosis. So it gives a picture of bacterial infection like leukocytosis, elevated polymorphs and neutrophilic leukocytosis.
Right, very good. Dr. Jagdish, any missing investigations which I had ordered at the time of admission?
All the basic investigation has been done. Now I like to do some ultrasound chest, sir, to rule out any pleural effusion, to decide about the treatment. And then since in our country tuberculosis is most common, I go do a basic manto test and gastric lavage and do the sputum AFP for CBNAT for tuberculosis. And then in addition, as sir said, nowadays mycoplasma is more common, so we can do the nasopharyngeal mycoplasma test and IgM mycoplasma. And then since the child is obese, I would like to do thyroid profile also in the child. Then just to complete, you can do urine routine and urine culture also in the child.
Very good. So we have like plenty of investigations, but on day one, I may not be able to ask for everything, do the basics. So we know that with the basic investigation, we know most likely it is a bacterial. High count, 3-digit CRPs, smear showing leukocytosis, probably like what we had thought, a bacterial infection. Now, One is in a private setup, one is in a government setup, one is doing OP practice. So I just want to know from each one of you, what will be your treatment prescription?
With the clinical setting, like we have found out that this child is having pneumonia. And from the radiological aspect, it seems like a moderately severe, probably a communicated pneumonia. So along with the symptomatic treatment like oxygenation, hydration, and nutrition, the specific antibiotic I would like to use should be amoxiclav, amoxicillin clavulanic acid, probably at a higher dose, 80 to 90 milligram per kg per day. And even though we haven't come out to a conclusion of the atypical organism, I'll be each to start on macrolide in this setup because it's quite well tolerated.
Right. In government, what you will start with?
As such, as we can see, the amoxicillin seems to be the drug of choice for the CAP. But still, since the child has been referred from somewhere else and treated elsewhere, and if the child is admitted in ICU setup, PICU, I would like to go in for higher antibiotics like usually we start on vancomycin.
Right.
That be a choice.
Right.
Or if the child is in the ward,
Okay.
if the child is not all that sick, we can usually we start with ceftriaxone.
Right. Okay.
That's what it's happening now. Even though the guidelines say it's amoxiclav.
Dr.
That's been
Jagdish.
happening.
In our rule setup, initially I start the child on amoxicillin 80 mg per kg in 2 derived doses. And then I will clearly explain the patient about the danger signs. The child has increased fever, and vomiting, not taking feeds. When the subtype is poor, immediately I advise the patient to get admitted in spite of this treatment.
So everyone is very clear. You need to admit, depending on setup. Suppose if the child is in the ward, like saturating normally, tachypnea, with this type of CBC, yes, co-amoxiclav. But if the child is going to get admitted with hypoxia, then we know the choice of antibiotics we don't want to maintain with co-amoxiclav, we'll give a higher antibiotic. Yes, well taken. So what I have done, co-amoxiclav along with azithromycin because the child's age was 7 years, along with supportive care because this child had obesity, this child had past recurrent infection with a chest pain. We did a chest ultrasound and a chest ultrasound abdomen too. Ultrasound abdomen, there were some findings which was suggestive of the common illness what we see day in and day out, bowel bladder dysfunction, urinary bladder wall thickening, then loaded colon loops. Ultrasound chest showed right paracardiac lower zone consolidation with air bronchogram, and they have suggested CT for further evaluation. So each one of you, I want your decision whether I should go for imaging now or what is your take on CT, because once you get the report, the parent also looks at it and asks why not CT. So what will be your take on CT now, each one of you?
With the clear-cut evidence of ultrasound showing consolidation with air bronchogram, I might not be interested in CT at this point. Probably if the child is deteriorating or showing signs of not improving, then I might consider CT. Again, if I suspect like a foreign body, if I suspect a bronchiectasis and necrotizing pneumonia, maybe I'll go for CT. My decision will be clinical and radiological evidence rather than going for a cross-sectional imaging.
Dr. Kumarave.
Yes, sir, I'll agree with Dr. Gopal Subramaniam. Like what is it, at this point of time, CT may not be necessary.
Right.
Because whatever the information we have got it with the ultrasound itself.
Right.
So I like to wait for CT because shifting the patient will be a little difficult at this point of time.
Dr. Jagdish.
Yes, sir. Same thing. Since the child is the first episode, got admitted for pneumonia, so I won't go for CT, sir. If it is second episode, definitely I will do a CT chest.
See, wherever you are, whichever place you are in, see, this is one thing. When you do have something in X-ray, you know this child, you can do an ultrasound, non-ionizing, and it gives you some information. Based on that, you start your treatment and see how the child is. Everyone says at 48 hours, yes, they are on the right track. You always allow the antibiotics to act. We always act in the good faith. Like, don't start with the highest medicine. We give what is the recommended in the guideline and go about. And we have done other investigations slowly, one by one came. IgM mycoplasma was negative, Manto was negative, sputum CB NAT was negative, urine culture, no growth, because child was obese. Yes, thyroid function we did, it was normal. Now, Gopal, what to observe while on treatment? You already said you will wait for 48 hours. What to observe while on treatment?
Again, I'll see the improvement, general improvement in the child's general well-being, the differences of fever, the decrease in tachypnea or respiratory rate. Again, the chest signs, the oscillatory finding. I'll go for pulse oximetry reading regularly. And if the child is not improving, then I might go for further investigations.
Right. Dr. Kumarvel, what investigation, if at all you want to repeat, you will repeat?
The only investigation that has to be repeated seems to be X-ray. If the child is not deteriorating, if the child is improving, we can wait for about 5 days or 7 days.
Right.
But if the child is deteriorating, if the cell is desaturating, or if any new findings develop, then we might have to repeat the X-ray immediately.
Very good. See, don't keep on. Just because you have a finding here, child is showing some sort of improvement, just for the sake of to find out how the abnormality in the lab values are, don't repeat. Okay. And Dr. Jagdish, when you will modify the treatment in this child?
In this child, we just wait for 48 hours to see whether the child is improving in the form of alertness, when the appetite is increased, decrease in the fever, and the respiratory is decreased. So when this is not happening, so we definitely think of change the treatment, sir. We can add some drugs.
Very good. See what we have done, co-amoxiclav, sorry for putting the trade name. We had given co-amoxiclav, we had given azithromycin, because child had constipation too, added a stool softener along with supportive medication. And on day 5, obese child, our IV lines, everywhere they had countered, so we changed over to oral because the child's fever has come down. So this was the repeat X-ray, because we know that the chest pain was most probably due to a pleural fluid. So, and we had repeated the X-ray. And Dr. Gopal, what is your view on the repeat X-ray?
Repeat X-ray at probably on day 2 or day 3, I might not repeat an X-ray. If the child is deteriorating, I will go for an X-ray, one thing. Second thing, if we are planning a discharge, I might do an X-ray to see the radiological clearance, at least to satisfy the parents. And even if the child is not showing much of an improvement in X-ray, if the child is clinically improving, I'll just stick on with my treatment on oral medications.
Okay, Dr. Kumarvel, how was the X-ray? Like
after 5 days, there's a good radiological resolution is there compared with the X-ray which was taken 5 days back, and there's no evidence of any pleural fluid or any pneumatocyl formation. Seems to be good since the bacteria is very goodly sensitive to co-amoxiclav.
Dr. Jagdish, what will be your prescription on discharge?
Yes, sir. Definitely child is improved, so I will discharge child with advise that continue amoxicillin, oral amoxicillin with 8 mg per kg in 2 days for 10 days duration. And then I will explain about the danger signs also. The child having a severe fever, any vomiting, when there is a lethargy, not taking feeds, definitely we will ask the patient to come back. And then in the meantime, I advise good hydration also, good rest, at least put leave for at least 7 days to school, don't rush. And then after 4 weeks, I can advise some immunization also, whether child had taken any missed vaccines also, I can advise.
Very good. Like what we had done, because it was a 3-digit CRP, we didn't want to miss out anything. So repeated the investigation, all were coming down. The inflammatory markers were coming down. We discharged. As the panelists say, why I have not written amoxicillin, why I have written co-amoxiclav. The moment you write amoxicillin, many times it is not available because it comes under the price control. So it is not available. And like instead of writing amoxicillin, there is nothing wrong in writing a co-amoxiclav. Okay, there are certain points in this child, like, you know, it's fever, chest pain, like high counts, 3-digit CRP with an X-ray problem. Clinically, you had a right lower lobe pneumonia with effusion. You need to find out whether the organism will be susceptible to the empirical antibiotic chosen. What I could have done or I should have done, probably a throat swab for respiratory pathogens, at least virus, if not the whole panel, virus and bacteria. But if the child is not showing improvement, then probably I can review the child, find out whether I need to wait for another 2 days or whether I need to do an investigation. It all depends on how the child is not showing improvement, still having high spiking fever. Probably you can wait for another 24 hours, 72 hours you can wait. But if the child is deteriorating within 48 hours, you know, you have to repeat the investigations, you have to modify your treatment, you need to escalate your treatment, you need to think of a possible complication. And like in 2025, this is what the review of imaging. No definitive gold standard exists for imaging complicated pediatric pneumonia. Clinicians will find it challenging to choose the best imaging technique for a given clinical scenario. This is one. Number two, ultrasound Doppler can show absence of blood flow if there is going to be necrotizing pneumonia. This is one thing which we need to sensitize our radiologists and ask for if the child is not showing improvement. And you know, severe forms of necrotizing pneumonia can be by staph aureus expressing your Pantan-Valentine leukocidin pore forming exotoxin, because it will lyse the immune cells and release the tissue damaging proteases. And another toxin, alpha hemolysin, it forms pores which will activate the NLRP3 inflammasome. This can lead on to necrotizing pneumonia. This NLRP inflammasome you can find out, but it's something like forming a government with multiple coalition partner. It need to have lot of mediators to form this NLRP. Why you need to be critical about this? Because when this NLRP3 inflammasome is dysregulated, it leads on to lot of inflammatory disorders, including your necrotizing pneumonia. Always guidelines say, depending on the sensitivity pattern in your area, choose the antibiotic. Suppose the child is deteriorating, these are the options, not the first line, but only when the child is not improving, deteriorating: meropenem linezolid, meropenem vanco, meropenem clindamycin. So we still have many questions unanswered in CAP. Why? Because even if they are going to have a lower respiratory tract infection, they can have impaired lung function over the whole lifespan. And they have followed up birth cohorts. They found out near doubling of respiratory associated mortality in adults if they are going to have pneumonia in children as in the childhood. So you need to be very cautious. Even though you have treated pneumonia, keep in the back of the mind that respiratory morbidity as they grow older may be higher compared to the general population. Now we'll come to the second scenario. 13-year-old boy. This happened in 2020. Fever, high grade, no chills, day 10, with no cough, breathing difficulty or ear discharge, vomiting or loose stools, no urinary symptoms, no seizure, bleeding manifestation or bone pain. He came to the hospital with fever. Your pickle was negative. Respiratory system examination, there was decreased air entry in both infrascapular area with crackles. There was no organomegaly, CNS was normal. So because older child, OP treatment, what they had given previously was Comox and azithrol as per the guideline. The hemoglobin was normal, the CBC was normal, platelet count was slightly higher, 4.77, ESR was 48. Smear was normal with mild thrombocytosis. He was referred with an X-ray. Immediately after X-ray, they have done the CT too. CT showed multifocal parenchymal opacities in both lower lobes with air bronchogram with minimal mediastinal adenopathy. This is the X-ray. So, Dr. Gopal, now will you do any further investigation in this child, because they have done many. So, what will be the investigations?
We have a child here who's presenting with 10 days of fever, and they've already got some investigations, and they've already got on some medications. But my idea will be to find out whether we are dealing with a typical organism or an atypical organism. Is it a resistant one? And I'll go for simple test to find out the other organ functions also. So before escalating or de-escalating the therapy, so I'll go for basic investigations to repeat the blood counts, differentials, the inflammatory markers. Again, the blood culture, as I said, again I'll go for a blood culture in this child also. The throat swab culture, again to rule out the mycoplasma, I'll go for mycoplasma IgM. And in a tropical setup, I'll go for to rule out other tropical diseases like dengue, malaria, typhoid and scrub.
Very good. And Dr. Kumaravel, what you will do?
The first thing is I'd like to check the dosage of amoxicillin that was given, co-amoxiclav, that has been given as OP, and also the dose of azithrol that has been given. Azithrol and amoxicillin could have been a better combination, but we need to check the dose. If the dose is, if the child has received the correct dose, probably we might need to escalate the dose.
Okay. Dr. Jagdish, will you repeat any investigation if the child's fever is going to continue?
Yes, sir. So in this child, actually came in 2020, sir. So I would like to think of COVID also in the child. So if the child had symptoms persisting after 48 hours, definitely I should repeat the test, like X-ray test also. Then other investigation, as Sir Gopal sir said, in addition to the COVID testing. And then in addition to that, I will look for the clinical symptoms. Child already had a tachycardia and tachypnea. So and in addition, I would like to see the saturations and then whether whether saturation is maintained or not. So definitely wait up to 48 hours and then again I repeat the investigations.
Why the panelists say I will repeat the investigations? Many a time we don't get results from standard lab. Why standard lab? Because we need something to start or modify our treatment. When we know the lab is not standardized, whether we can accept whatever results they had given, always we'll have it, like we'll have the doubt. Okay, clear the doubt, because child is not doing well, that is why child has come to a higher center. So there is no harm in repeating once again the basic investigations. Day 10, always we are in a tropical country, think of tropical infections too, don't miss out that. And with X-ray, we may not be able to find out this finding, okay, this is the organism. We don't have anything like that. So what we did, like I had given ceftriaxone because I didn't know they had already given co-amoxiclav. What is the next step? What I will do? Yes, I will modify the antibiotic to a third generation cephalosporin. I repeated the investigations. Yes, the previous investigation, that was also fine. This also tells me that the previous investigations did not reveal. Same with me. The ESR was 30, the CRP was 42. Why did I do ESR? Even though we have so many sophisticated investigations, ESR is non-specific, but certain things have it as a baseline because the shadows, whether it's because of infection or inflammation, for that, if it is going to be an inflammation due to a connective tissue disorder, your CRP can come down, whereas your ESR can go in 3 digits. Okay, the renal function test, liver function test, everything was normal. At 48 hours, he came without any cough, but once he came to the hospital, he started coughing continuously. His sleep was disturbed. He was not even able to take anything. So I need to add one antibiotic. So Dr. Gopal, what you will do, or like what antibiotic, if at all you want to add, what you will add?
Probably since the child is not improving within 48 hours of our treatment, I need to escalate my antibiotics. Probably I think I'm dealing with an atypical organism. So my prescription is to add doxycycline or azithromycin in this case.
Very good. Okay. So, did the repeat X-ray and like probably like this is what I have done, and at 96 hours after adding the antibiotic after another 2 days, the fever alone came down, the cough did not come down. In addition to that, the child developed a wheeze. In between we had some more results. The manto was negative, the smear was normal, the dengue IgM, the scrub IgM was negative, the gastric aspirate for CB-NAT was negative, blood culture was sterile. Then at 4 days, day 4, repeated the X-ray. Dr. Kumarvel, like compared to the previous X-ray, can you tell me what's happening now?
Yes, sir.
And what should be the next step in management?
Compared to the previous X-ray, this X-ray shows little resolution of the opacity, and there seems to be little hyperinflation. Otherwise, the child has not developed any complications like effusion or neutrophil formation. So I think the child is responding to the treatment. Even though the cough is there, child seems to be improving.
Very good.
Radiologically.
Right. Usually parents want complete resolution of symptoms. Otherwise, the cough is still there. The first thing they will come with, sir, day 10 fever, child has not settled down, so please help me, like make my child better. When the fever comes down, they will not tell fever came down, there was no fever. Sir, cough, seriye agla. So, like always, what is there, they will always try to exaggerate, and we had to keep them for 9 days in the hospital, because when he came to the hospital, there was no cough. Sir, with your medicine only cough developed, with your medicine only his wheeze has developed. So we had no other choice. Okay, maybe like we added more supportive care on day 9 and day 10. There was no fever, cough decreased, wheeze decreased. We were planning for discharge. So this was the X-ray on day 9 or day 10, because some of the parents, they become Google doctors, they try to drive us, but don't take everything into this. This is what we can do. So what inputs you will do, or what will be your discharge advice, Dr. Jagdish?
Yes, sir. Based on this, definitely there is a clinical improvement, and there is a radiological improvement also. So you can safely discharge a child on day 10. So I'll advise to continue since we started ceftriaxone, we advise the child to co-max club again 80 mg per kg, ask the patient to continue up to 10 days. Since we started the child on doxycycline, we ask the child to continue 5 mg per kg in 2 doses for another 7 days. Then again advice regarding the good hydration, good diet, good rest, and then advice regarding the danger signs also to the child.
Very good. See what they have done, like we are going by, when they came on day 10, they had already given co-amoxiclav for 5 days, azithromycin also completed 5 days. When we asked the prescription, you know, the dosage was 20 milligram per kg of co-amoxiclav. And azithromycin, we found out every time the child had the tablet, child vomited. But as far as the parents are concerned, they said, yes, I had given the medicine. He vomited, that's all. Like this is what their casual reply was. So that is why at the end of 48 hours, added a medication. What medication did I add? Instead of like azithromycin, I gave clarithromycin, because if I'm going to give azithromycin, this is what I had given. This will be the like reply which I'll get from the parents will lose confidence. So I just modified the molecule to clarithromycin, and you know clarithromycin is costly also, so they'll keep quiet, because for them costly medicine means very good effect. This is what it is there like implanted in their brain. There was gradual improvement, because when the child came, there was no cough, there was no wheeze. Just because the child came to the hospital, that was the time the cough, wheeze, everything came, and mycoplasma IgM was positive. And because tech-savvy parents, you need to deal with them slightly differently. So you have a variety of chest X-ray. And on day 56, when X-ray became normal, they also stopped asking question. So I stopped writing further X-rays. Mycoplasma pneumoniae, it is endemic worldwide. You have high attack rates within families. Transmission rates are up to 80% for household children. Transmission rates are up to 80%. Children are often the reservoir from whom mycoplasma spreads. Children less than 5 years, you will have milder illness. Probably that is why we don't look for mycoplasma, or most of the investigations, we are not going to look for mycoplasma less than 5 years. Probably in another 3 to 5 years time, even our textbooks say mycoplasma even in less than 5 years. This is what we will be reading after another 4 to 5 years. See, it targets the ciliated respiratory epithelium due to direct bacterial invasion. You have a toxin by name CODS toxin. The explanation, the expansion is adenosine diphosphate ribosylating and vacuolating toxin. This is an exotoxin. This causes damage to the respiratory tract. This can cause even fatal disease. The distinct aspect or the character of mycoplasma is the ability to induce production of cold agglutinins, that is antibody against the eye antigen or RBC. That is why you have the cold agglutinin in most of the children. You have intractable non-productive cough. You can have tracheobronchitis or atypical pneumonia. Many a times, whenever you see a consolidation, we think of strep pneumonia, staph, Klebsiella. But mind you, mycoplasma also can produce lobar consolidation, can produce large pleural effusion. It can also lead on to necrotizing pneumonia. This is the respiratory symptoms. The non-respiratory symptoms, CNS, you ask any ICU specialist, they will say, when the child comes with altered sensorium, it could be mycoplasma, scrub, ADEM, okay, because the presentations are different with mycoplasma: encephalitis, ADEM, ataxia, aseptic meningitis, GBS. But skin is one thing, mucocutaneous disease, maculopapular rash. Hematological, you can have decrease in the hemoglobin, you can have Coombs positive test, and you can have monoarthritis too, because this can have extra pulmonary manifestation. So whenever a child has a X-ray finding like this, don't lose your heart. Make sure you spend time on the general examination, find out if there are any other manifestation just in the general examination too. IgM antibodies. Previously, mycoplasma IgM antibody was the one we used to do, but it is not detected within the first week after symptom onset. This is the first fallacy with mycoplasma IgM. The second is, once it becomes positive, it can remain positive for 6 to 12 months after infection, sometimes even years. So if mycoplasma IgM is positive, doesn't mean that it is an acute infection. So what is the best test nowadays? It is the PCR from a nasopharynx or throat swab. If you are going to do both, the combination of both is going to increase the sensitivity to pick up your mycoplasma. And it is going to be positive earlier in the course of infection, even before your mycoplasma IgM becomes positive. You know, mycoplasma IgM with all its negatives, previously we were talking only about, yes, mycoplasma IgM, but nowadays after your COVID, you do have lot of PCRs available. Mycoplasma, you can detect it. Cold agglutinin, it is positive in only 50% of the patients. Why you need to take it with a pinch of salt? Almost all the viral infections can induce cold agglutinin, but the titer will be on the lower side. In mycoplasma, it will be present in high titer. Treatment does not assure eradication. Mycoplasma is sensitive to macrolides. you always use empiric treatment even before you get the results. And even if you are going to use appropriate antibiotic, it does not shorten the duration of illness. You do have lot of macrolide resistant mycoplasma pneumonia suspect in patients with severe infection who are not going to respond to your macrolide in 48 hours of treatment. What are the other antibiotics what you can use? Doxycycline or fluoroquinolones. This is what my panelists said. And sometimes you need to use immunomodulatory therapy, corticosteroids or IVIG. These are the two common immunomodulatory therapy what the child may need in PICU. I thank the panelists for an enlightening discussion. Thank you all for coming in good numbers. Thank you.
Thank you, sir. Thank you.
Thank you very much, sir. So please be on stage for distributing the mementos. I request Dr. Gauri Shankar sir to distribute the mementos to the panelists. Dr. Gopal sir. Dr. Kumarvel sir. Dr. Jagadish sir. I request Dr. Gopal sir to give the memento to Dr. Gauri Shankar sir. Thank you, sir. Thank you very much.
Okay, thank you.
Sir, I have a doubt, sir.
Yes.
Sir, this is.
Ah.
So in this the same scenario, if the total count is 20,000, but the CRP is negative, then we will go for antibiotics or we can watch for a viral infection like that.
See, till 2024 January, high CRP, high total count, yes, kannamudite, it is bacterial. After 2024 January, after the deluge of adenoviral infection, even if the CRP is high and total count is high, am I dealing with adenovirus? So, nowadays, probably you need to use more of your nasopharyngeal PCR to get at whether it's a viral or viral bacterial. Previously, if it is more than one organism, oh, it is something like a bystander in the throat. Now, with more knowledge, we know there can be viral infection along with a bacterial infection. So, we need more knowledge in the knowledge gap area. So, just with CBC alone or CRP alone, I may not be able to. So, that is why many questions are still unanswered. That is why I put.
Any clue for adenovirus, sir? Clinical?
Unless you test, you will not be able to clinically know.
Sir, the reason for chills with the pathogen, sir, the chills in a fever child, is it a bacterial or viral? Any clue like that?
We will not be able to. Like, it all depends on how that particular genetic system, how the genes are there to induce or to fight an infection. If the amount of inflammatory release, like markers which are released from the cells, if it is going to be high, your fever may be touching very high. So, genetic propensity also plays a part, but it is a separate topic by itself. Probably I may not be able to explain everything within 1 minute time.
Okay, sir. Okay, sir.
Thank you.
Thank you, sir.
Thank you, sir. Now we are at our last session. I welcome our chairperson, Dr. A. Arul Kumaran, sir. I welcome our speaker, Dr. Ram Kumar, sir. Yes, sir.
Good evening, good evening, everybody. First of all, I thank Dr. Rajendran sir, President, and the organizing committee of KONGU PEDICON for inviting me to give this talk on thyroid disorders in children and adolescents. So in the next 20 minutes, I'll be sharing mostly the important, the prototype thyroid disorders that can present in our day-to-day practice. All our case all our like important cases which I have seen previously when I worked in ICH and in my own clinic, and now in Savita and Apollo Children's Hospital. So I'll be touching upon some important case scenarios on congenital hypothyroidism, including the transient one, ectopic lingual goiter, thyroglossal cyst, autoimmune hypothyroidism and autoimmune Graves' disease, central hypothyroidism versus TBG deficiency, and hypothyroidism in relation to sexual precocity and Turner syndrome. So I'll go with the first simple case. It's a 3 days old neonate with the birth weight of 2.8 kg, detected to have indirect hyperbilirubinemia. This is the commonest reason for doing a thyroid function test in those places where routine neonatal screening is not done. Free T4 is 0.5, TSH is 520. So it's a case of primary hypothyroidism. It's a 3 days old neonate. It's a congenital hypothyroidism. Ultrasound was done, which showed a presence of normally size and location of thyroid gland. So in congenital hypothyroidism, if the thyroid gland is located in normal size and location, it's probably a case of dyshormonogenesis. The usual recommended treatment is 10 to 15 micrograms per kg. So if you calculate for the, usually we start with a higher dose. If you calculate for 2.8 kilogram, it will roughly come around 43 micrograms per day. So how do you calculate the thyroxine dose requirement? Based on age group and body weight, and also based on the etiology, if it is congenital or whether it is autoimmune, or whether it is based on the severity, whether it is a mild or whether the TSH is very much elevated, whether it is a severe hypothyroidism, and also based on the symptoms as well as duration. The most important is by the age group and the body weight. So this is the table that we usually follow while calculating the thyroid dose. In newborn, it is 10 to 15 micrograms per kg, which the per microgram per kg usually comes down by, in an adult, it is 1.6 micrograms per kg. For example, if the weight of an adult is around 60 to 60 kg, it will approximately come to around 100 micrograms. That's the usual strength of a thyroxine tablet. As I said, the recommended dose is 10 to 15 micrograms. Approximately you will need a dose somewhere between 37.5 to 50 micrograms per kg. And in mild hypothyroidism, if the TSH is not that grossly elevated, you can even start with a low dose of 8 to 10 micrograms per kg. So the tablet in congenital hypothyroidism, that need not give it in, it's not possible to give it in empty stomach. You can give it in expressed breast milk, crush the tablet and give it in expressed breast milk. Avoid giving calcium or iron at least for 4 hours after giving the thyroxine tablet. 35% of cases can have a transient congenital hypothyroidism, so it's better to stop and recheck after 3 years. But this rechecking is usually not done if the TSH has been in between also it's elevated, or if it is an ectopic location or the thyroid is actually absent. So in these conditions, there is no need to stop the medications. So the most important factor in congenital hypothyroidism is start the treatment early. If you start the treatment early, then the verbal development, the psychomotor development, and the global IQ scores are similar when compared with the unaffected siblings. So compare the case 1 with the case number 2. This is a 4-year-old girl born of second-degree consanguineous marriage. TSH was documented to be more than 100 at 1.5 months. She was on thyroxine till 2 years of age and then stopped thyroxine. She presented at 4 years of age. So TSH, when she came, the TSH and free T4 were normal, and ultrasound showed a normally located thyroid size, the thyroid and size was normal. So this girl definitely had a congenital hypothyroidism, but now at 4 years of age, it has become euthyroid. So it's a transient congenital hypothyroidism. We did a genetic analysis for this child, which turned out to be a homozygous mutation of DUOX2 gene in exon 22. She was born of a second-degree consanguineous marriage. DUOX2 gene codes for dual oxygenase. That is one of the enzymes necessary for thyroid hormone production. Why this happens? why they become they were hypothyroid and why they become euthyroid subsequently is because of the compensation by the there is another enzyme called duox1 which compensates as they grow older, but at times of puberty or during pregnancy they may manifest subclinical hypothyroidism again. So they need to be followed up once in 6 months or in a year. So what happens if congenital hypothyroidism remains untreated? This is one of the girl whom I have seen in Egmore Children's Hospital. So you can see she was having all the classical features of congenital hypothyroidism. She had large anterior frontal developmental delay. These are all the features of untreated long-standing congenital hypothyroidism. Developmental delay, lethargy, speech delay, hoarseness of voice. You can see the wide eyes, depressed nasal bridge, narrow palpebral fissures, swollen eyelids, delay in dentition, open mouth, thick, broad, protruding tongue, delayed puberty, dry, scaly skin, short fingers, stunted growth, hypotonic muscles. Occasionally, we may see a generalized muscle pseudohypertrophy. So I said earlier about the classification as transient and permanent. This is a etiology-based classification. Primary and secondary. Primary means the problem is in the thyroid gland. Secondary means the problem is in the pituitary or hypothalamus. Among primary causes of congenital hypothyroidism, we have dysgenesis, TSH receptor defect, dyshormonogenesis, and maternal medications. TSH receptor defect is if they have mother has Graves' disease and they have a TSH blocking antibody, or maternal medications may be because of propylthiouracil usage or antithyroid drugs in the mother. Secondary congenital hypothyroidism can be because of isolated TSH deficiency, which is quite rare. Multiple pituitary hormone deficiency is relatively common. Among dysgenesis, we can have agenesis, complete absence of thyroid gland, hyperplasia, poorly formed thyroid gland, or ectopic located thyroid gland. And how do you diagnose this? By doing a technetium thyroid scan. So thyroid scintigraphy is used not only for congenital hypothyroidism but also for other conditions including thyrotoxicosis as well as for nodule, any thyroid nodule. So it can help us tell if there is the thyroid gland is absent. It can help us tell if the gland is located in an ectopic location, and in dyshormonogenesis it will show a normally located gland with a normal or a high uptake. Okay, in our first case, we didn't do a technetium thyroid scan because ultrasound itself was showing a location of size. Suppose ultrasound was not able to show the size, location of thyroid gland, then we may have to do a technetium thyroid scan. Sodium iodide importer defect, this is one thing which we can diagnose by doing a technetium thyroid scan itself in congenital hypothyroidism. Thyroiditis, if it is a thyrotoxicosis, whether the uptake is low or the uptake is high. Uptake is low is thyroiditis, if the high uptake is hyperthyroidism. And if there is a nodule, whether it's a hot nodule or whether it's a cold nodule. This thyroid scintigraphy is helpful in arriving at what is the etiology, but it is not going to alter the treatment. So do not wait for the technetium thyroid scan. Start the thyroxine as early as you make the diagnosis of congenital hypo. You can you see the SSN, that is suprasternal notch. The first arrow represents the chin. So you can see that between the chin and suprasternal notch, there is no uptake. The uptake of technetium is behind the chin, slightly above. That is in the lingual location. This is a case of ectopic lingual thyroid. This is the same patient we can see in the CT scan, located at the base of the tongue. This is a video of the girl. Can you appreciate the thyroid located at the base of the tongue? Sometimes when you do ultrasound, we thought it is ectopic, but it will turn out to be a thyroglossal cyst. The main problem with thyroglossal cyst is there is a high risk of developing an infection, and it may develop into an abscess and may result in a fistula. So this is a boy whom we have recently seen in the Apollo Children's Hospital with a thyroglossal fistula. So the definitive treatment for thyroglossal cyst is cyst trunk operation. That is, you have to go for the excision. So what if you don't remove the thyroglossal cyst? There is a high risk of infection, they may develop a recurrent abscess, and they may result in a fistula formation, or there is a slightly higher risk of malignancy. There are two of my patients, one is 55-year-old male, another is 20-year-old girl. They are not opted for thyroid cyst trunk operation. So far, they have not developed infections. So some cases, small, asymptomatic, and never infected, they may choose to get a periodic follow-up, but we have to explain the above 4 risks. So this is on another patient. You can see on before swallowing and after swallowing. This is a typical exam question. On swallowing, the thyroglossal cyst moves up. Not only the thyroglossal cyst, the thyroid also moves up because they are attached by the pretracheal fascia with the larynx. So on swallowing, both the thyroglossal cyst and thyroid moves up. But on tongue protrusion, only the thyroglossal cyst moves up because that has connections, embryologic connections with the base of the tongue. This is a case I saw recently in Savita Medical College. This is a straightforward case, 11-year-old girl on routine evaluation with recent weight gain and fatigue. Free T4 is 0, TSH is 100. Ultrasound showed multiple colloid thyroid nodules, anti-TP was positive, bone age is 8 years. So it's a straightforward case of a primary autoimmune hypothyroidism. What is important here is how much to start with. In this age group of 11 year, normally the recommended is 2 to 4 micrograms per kg. But the important point here is the delay in the bone age. Whenever there is a long-standing untreated hypothyroidism, if you calculate based on the 4 microgram per kg, the 35, it will approximately come to 140 micrograms. If you suddenly start, who has been living with hypothyroidism, suddenly you start with a very high dose, and they may develop some side effects. So it's always better to start with 2 microgram per kg. That also what we do is, especially if the bone age is much delayed. If you look at the growth chart, the height age is also corresponding to 8 years. Bone age is also 8 years. Start with half the dose. The recommendation here is 75 micrograms per day. 36 into 2 is 75. Start with half the dose for 2 weeks and then make the full replacement dose. And then slowly uptitrate it based on the TSH. This is a 13-year-old male who underwent surgery for craniopharyngioma and also received radiotherapy and was on hydrocortisone replacement. When we saw in 2021, his free T4 was normal. In 2023, he came with the total T4 was 5.1 and TSH was 2.9. So total T4 is low. This normal TSH, we call it inappropriately normal, because when the total T4 is low, body should try to produce the TSH much, much higher, but here it is only normal. So it is an inappropriately normal TSH. We did the repeat free T4, which was also low. So it's a case of central hypothyroidism. There is no doubt here, because he is already a case of craniopharyngioma, already on hydrocortisone replacement. And usually here also, this is a condition, here also we start with a very low dose and try and slowly uptitrate to maintain the free T4 in the mid-normal range. After cranial radiotherapy, all the pituitary hormones can get affected, but not at the same time. They may get at some point, sometimes years later also. The most radiosensitive is the growth hormone. Fortunately, the child was having a normal stature, and gonadotropins followed by the TSH, which may manifest even years later. So can you see the report? This is another boy who is 12-year-old, who came with this thyroid report. Leave alone the symptoms. We can take it as routine testing. Total T4 is 4.2, which is low. TSH is normal. It's similar to the previous case. Total T4 is low. TSH is normal. We ordered for a repeat free T4 with the total T4 again. Total T4 was again low, but free T4 is normal. In the previous case, free T4 was also low. So there is something. Thyroid is not low, but something which is bound with the thyroid is probably deficient. So thyroid circulates in the blood bound with a binding protein, that is thyroxine binding globulin. So deficiency of thyroxine binding globulin, you can get a report like this. So this is a case of a thyroxine binding globulin deficiency. This is not a serious condition. It is X-linked. He was also a boy. It is transmitted from the mother, but mother may not manifest the symptoms. It's a benign condition. Total T4 will be low, free T4 will be normal. Males are affected. Mothers may not express, do not require any treatment. This is a 10-year-old girl who actually presented with short stature, diagnosed as hypothyroidism on thyroxine 88 micrograms. This was the case I was telling Dr. Nadu sir yesterday. So this was diagnosed as short stature, diagnosed as hypothyroidism on treatment for almost 3 years, and then they came to me that the height did not pick up. So this is where the growth chart, it's not just you made a diagnosis, but after your treatment also you have to see whether the response to your treatment is shown in the growth chart. If you plot the growth chart, there is no improvement. The child continues to remain short, so which means that we are probably missing something. The etiology of short stature is not just hypothyroidism, but could be due to other reasons, including growth hormone deficiency. But most commonly, we should think of, this is an autoimmune condition, so we should think of other autoimmune condition which can also cause short stature, like celiac disease. This was a girl from Kolkata. Another important thing, if you look at, she was actually, when she came to the clinic, she was actually wearing a kerchief here. I asked to remove her. You can classically see the short fourth metacarpals. She turned out to be a Turner syndrome. So karyotyping showed 45XO. So whenever you see hypothyroidism, height is not picking up, consider other etiology. Here it is Turner syndrome, but in your case it may be other reasons as well. So the treatment is not just thyroxine, but also growth hormone therapy. This is one of the first case of a classical syndrome I have seen. A 6-year-old girl who presented with vaginal bleeding and breast development, no height gain, and puffiness of face. We can see the total T4 is low, TSH is high, antibodies are positive, a straightforward case of a primary autoimmune hypothyroidism, but LH is low. So she had a precocity with a low LH. It's a peripheral precocious puberty. She also had a very, very high levels of estradiol and prolactin. Bone age was very much delayed. Ultrasound showed a normally located thyroid gland. Ultrasound abdomen showed multiple cystic ovaries in both ultrasound and CT. MRI initially reported as pituitary macroadenoma. So anyone will think high prolactin and pituitary macroadenoma will think of prolactinoma, or high estradiol and multiple cystic ovaries will think of a estradiol secreting neoplasm. But all these are all part of a single entity, which is primary hypothyroidism, and it goes by a name of a syndrome called Van Mick-Krumbach syndrome. The treatment here is again thyroxine, which will cause resolution of all these symptoms. Again, start with the low dose if the bone age is much delayed. So she had short stature, precocity, galactorrhea also, delayed bone age, multiple, you can see the multiple cystic ovaries. We can see single follicular cyst, but here will be multiple follicular cysts. This is different from polycystic appearance, PCOD. Pituitary hyperplasia. Here the pituitary gland is uniformly enhancing. In macroadenoma, we will have a heterogeneous appearance. However, the radiologist reported as macroadenoma only. But there are only 2 conditions where you can get an appearance like this. Pituitary hyperplasia during pregnancy or puberty or in primary hypothyroidism. The second condition is inflammation. Inflammation of the pituitary, lymphocytic hypophysitis, where you can get a similar picture. This was a case report. So in the same case, when we started on thyroxine, you can see the response to thyroxine. She was on follow-up for a couple of years in AIMS. We can see this 25 centimeter in 2 years, you don't even get in growth hormone deficiency when we give growth hormone therapy. So she lost weight initially because of the fluid accumulation. She lost weight and then started gaining both height and weight. It's a 13-year-old boy who presented with poor weight gain, frequent defecation, poor academics, recently noticed thyroid swelling, palpitations, tremors, and nervousness and tremors. On examination, there was tremors but no exophthalmos. Free T3 was much elevated and free T4 was elevated, TSH was suppressed. A straightforward case of a thyrotoxicosis. The clue here is free T3 is much more elevated when compared with the elevation of free T4, which suggests endogenous. If free T4 is more elevated, it is exogenous. Ultrasound showed a diffuse goiter. The technetium thyroid scan was done, which showed a high uptake. So whatever technetium has gone into the thyroid gland. So it's showing a high uptake. So it is a case of Graves' hyperthyroidism. The diffuse uptake is Graves' disease. And TSH receptor antibody is used to confirm it, which was positive in this case. So thyrotoxicosis due to hyperthyroidism due to Graves' disease. Treatment is 1 to 2 milligrams of methimazole along with propranolol, same 1 to 2 milligrams per kg. So Graves' eye disease is very uncommon in children, but we saw a case of Graves' eye disease in a 9-year-old girl in Apollo. So this is a technetium thyroid scan appearance. We can see the diffuse uptake in Graves, toxic nodular uptake, multiple uptake is commonly seen in adults. This is the last case. So 7-year-old girl from Dubai, we saw this here. Ultrasound was done for the neck swelling, which showed both the lobes are enlarged and heterogeneous. They didn't describe any nodule. This was done in Dubai, but they documented some lymph nodes. TSH was 2 and anti-TB was 496. Otherwise, normally we call it euthyroid, antibody positivity, risk of hypothyroidism, and we just follow them up. But because of the lymph nodes, we did a repeat ultrasound, but it showed multiple thyroid nodules with TIRADS 3 nodule. TIRADS 3 nodule. Normally, TIRADS 3 is a scoring system used to decide whether FNAC is needed or not. When the for TIRADS 3 score, size should be more than 25 to go for a FNAC. I'll come to it next slide. But still, we thought this is very uncommon in a 6-year-old to have a 16mm nodule. We'll go ahead with FNAC. It turned out to be a papillary carcinoma thyroid. We did a total thyroidectomy with lymph node dissection. Biopsy confirmed as multifocal papillary thyroid carcinoma with lymph node metastasis. So this is the TIRADS scoring. If you see the TIRADS score, more than 2.5 is the recommendation for FNAC, then do not apply this TIRADS scoring for children. This may be used only for adults, but you have to decide based, even if the TIRADS score is not any suspicion, go for a FNAC. So take home message, reevaluate for transient congenital hypothyroidism, even if the initial TSH is more than 100. Do not operate on pituitary hyperplasia or multicystic ovaries. Both resolve on thyroxine supplementation. Early diagnosis is crucial in hypothyroidism. In fluid-borne hypothyroidism, start low and then escalate. Diffuse high uptake in thyrotoxicosis is Graves' disease. Cranial radiotherapy, watch for pituitary hormone deficiency even years later. Low total T4 with a normal free T4 is not a pathology. And if child remains untreated, even on replacement of thyroxine and TSH remains normal, think of other possibilities. Thank you. And I will take my, this is my one of the first CB we started in IOG on Turner syndrome. So now after 12 years we are finally forming a society for the Turner syndrome girls. If there is a time, please visit the website. And if you want to connect with me, you can connect in either of these numbers. Thank you.
Thank you, sir. That was a wonderful session with excellent case studies on thyroid. Thank you, sir. Sir, please be seated on the... I welcome Dr. Shanmugapriya ma'am for the next session on pediatric syncope.
Thank you for the introduction. I am Dr. Shanmugapriya from Hindustan Hospital. Let us discuss about the pediatric syncope. Is it heart or the head? Okay, I have tried to make it as simple as I can. This case scenario, 15-year girl, it's a common scenario, studying in the 10th standard, attending her school assembly, felt giddy and fainted down. Everybody got panic and rushed her to the hospital. And her parents came. But she recovered fully within 30 seconds of episode. This is a syncopal attack? Yes. By definition, to say it as a syncope, there should be a sudden brief loss of consciousness and there should be associated loss of postural tone and the recovery should be quick and spontaneous. So this is a case of syncope. So usually the syncopal attacks are common in children. It accounts for 1 to 3% of emergency department visit with an overall incidence of 0.1 to 0.5% in the pediatric population. Even a benign syncopal attack can generate extreme anxiety if it happens in a general public situation. So they will go in for a battery of expensive low yield tests which is not of any use. So incidence peaks around 15 to 19 years of age with greater in girls. During syncopal attack, there will be bradycardia associated with hypotension. So coming back to the case, after the parents came, we were on probing the history further, they said that they went for a night show and their child slept late and also she skipped her breakfast that morning. Examination wise, vital systemic examination were normal. Now we come to a conclusion that it is the commonest vasovagal syncope. It is the most commonest cause in children, accounting for about 80%. Usually 15% of young children would have experienced at least one episode before their adolescence. So vasovagal syncope, usually it's characterized by a classical precipitating factors such as decreased sleep, either due to studying for the exam or other reasons, or decreased fluid intake during summer days, and skipping breakfast, anemia, bleeding with or without a viral illness. These precipitating factors will be there with a triggering factor such as prolonged standing in a school assembly or mid-afternoon sports period, or sudden change in the posture with an emotional stress, or sometimes in a warm crowded places in a mall like that. The triggering factors will be there. Usually the vasovagal syncope, it occurs in the 3 phases. Prodrome phase, followed by loss of consciousness, which is momentary, followed by a complete quick recovery, spontaneous recovery. So during prodrome, sweating, facial pallor, all because dilatation, pupillary dilatation, palpitation, all occur because of the autonomic activation, as well as the blurring of vision, lightheadedness. This is due to these momentary cerebral and retinal hypoperfusion. So these neurally mediated syncope is due to the malfunction of the autonomic nervous system, usually in response to a certain stimuli. In this, vasovagal is the commonest cause. When we stand for a prolonged period of time, then the children, there will be preload decrease, which will decrease the cardiac output and hypotension. That will finally lead to the activation of the L-mechanoreceptors, leading to the stimulation of the basal-salix reflex. That will cause bradycardia and hypotension. Most of us would have come across this scenario. Even before giving injection itself, the child would have fainted. Even the site of injection or a site of the blood, even the staff nurses would have fainted. So vasovagal syncope is the most commonest form. And then another thing is coughing, laughing can cause a syncopal attack. Swallowing, micturition syncope, when it occurs in a specific situation, this is called a situational syncope. This occurs because of the stimulation of the medullary vasodepressor region, because of the afferent pathways through all the receptors located in the specific areas. So coming to the next scenario, this is a 9-year girl evaluated for 2 episodes of syncope. One occurred when she was carrying a bucket full of cloths upstairs and she collapsed on the top stair. The second episode, she was dancing along with her sister in front of the TV and she collapsed suddenly. What are you thinking in terms? What could be the etiology? Anybody? So this baby was evaluated in a neurological OPD and started as complex partial seizures with valproate. But there is no resolution of syncopal. It again recurred. Okay. One history, most important clue in this history, it occurred in the exertion. Whenever the child exerted, the syncopal attack occurred. So mid-exertional syncope history is a very important clue that we have to work up for a cardiac. So that is very important clue, mid-exertional syncope. So when we examine, there was a grade 2 parasternal heave with a loud P2 and ECG revealed RVH with a strain pattern, echo revealed pulmonary artery hypertension. So it is a cardiac syncope. It is not neurological. So another case scenario, 3-year previously healthy boy presented to the emergency department. He was playing in his daycare. He suddenly fell down to the ground, became unconscious for 2 minutes. His vital examination including sugar, electrolytes, CBC were normal. What could we think of in this scenario? Again, this is an exertional syncope. The child was playing well, so he fell down. So whenever there is an exertional syncope, we have to have an ECG has to be done to rule out a cardiac cause. You can see the shark fin ST elevation in V1 and V2 leads along with the T wave inversion. This is type 1 Brugada syndrome. So even if you don't know the ECG interpretation, nowadays we have technology to interpret it. So whenever there is a mid-exertional syncope, ECG has to be done. So we define cardiac syncope if it is caused by bradycardia, tachycardia, or hypotension due to low cardiac output, or acute vascular dissection. Nowadays it is very common as we have more and more Kawasaki children are getting recovered, so that has to be monitored. Mid-exertional syncope, we have to evaluate cardiac pathology. So cardiac, it could be either structural as in the first case, or it could be dysarrhythmias as in the second case. which all can cause hypertrophic cardiomyopathy, anomalous coronary artery, or myocarditis, or arrhythmogenic right ventricular dysplasia, valvular dysfunction, especially aortic stenosis, dilated cardiomyopathy, pulmonary hypertension, congenital heart diseases. Dysarrhythmias, we have to think all these things. So whenever there is a cardiac syncope, because of the increased demands during the exercise, they may not be able to meet the demand. So there will be a history of dyspnea on exertion and chest pain when if it is due to the outflow obstruction. In arrhythmias, you can have a sudden unexplained death in the family. Sometimes they may not say it as such. We have to probe the history. They may say that when in the family they ride a cycle and they died on the, no, we don't know the cause. Like that sudden unexplained death, we have to probe further. He was a best swimmer, but when he swam, he drowned and death, we don't know the cause. Like that sudden unexplained death, it may not be simple. We have to probe the history further. So coronary events, past history of Kawasaki disease or syncopal chest pain attacks has to be evaluated. So though cardiac causes accounts for 1 to 5% of syncopal attacks, it can result in a sudden death. Syncope is telling you something is not good in the child. And if it is there, it is due to mid-exertional syncope, we have to evaluate cardiac pathology to defer the sudden death. So next scenario, 11-year boy with symptoms of recurrent dizziness and syncope, which was lasting for more than 3 minutes. Each time it occurred while he stood up from his sitting posture. Okay. On probing the history, there was a history he reduced water intake intentionally to lose weight, which was misguided by his friends. Examination was normal, except but the vitals showed orthostatic hypotension. So it is more commonly due to volume depletion, more in young than the POTS. So orthostatic hypotension, usually if it is a classical, there will be a fall in systemic BP, more than 20, or a diastolic BP more than 10 when they assume the standing posture. Usually classical orthostatic hypotension, within 3 minutes, there will be a sustained reduction which is attributable to the anatomic dysfunction. So it is similar, POTS is similar, that is postural orthostatic tachycardia syndrome. In orthostatic hypotension, when they change the posture, there will be drop in BP, that's it. In POTS, there will be increase in heart rate. That is the difference between both the things. But orthostatic hypotension is more common in younger, while POTS is common and usually it occurs after puberty. So in conclusion, orthostatic hypotension, it can have a simple etiology like fever, dehydration, but more chronic conditions like autonomic nervous system dysfunction has to also to be looked after. So this is a simple schematic diagram. See, if we change the posture from sitting or lying down to a standing posture, normally there may not be a much change in the heart rate or a BP. But what happens in vasovagal, because of the abnormal stimulation, there is bradycardia and hypotension. That is the same in the orthostatic hypotension. There is a fall in BP, but there won't be any change in the heart rate. In POTS, that is postural orthostatic tachycardia syndrome, there will be increase in the heart rate, and the heart rate increase should be more than 30 beats per minute, and in adolescent it is more than 40. Okay, next scenario. 14-year girl, after she finished her 1 kilometer running race, stopped at the finishing point for 5 minutes and fainted. What could be the reason? So this is post-exertional syncope. See, what happens when the athletes, when they run, there will be more pumping of the calf muscles. So venous return will be very good. Suddenly when they stop, the muscle reduced because of the reduced pumping of the lower extremities, but the cardiac contractility will be continuously remain. So there will be a syncopal attack. This is post-exercise syncopal event. It has the same mechanism as vasovagal syncope. Next scenario, she's a 2-year kid, fainted suddenly for 2 seconds, followed by a normal sensorium. While sitting in her chair, she had multiple episodes. What could be the reason? Here there is no change in posture, there is no prodromal symptoms, no exertion. Yes, very good. So in this scenario, we will think of absence or atonic seizures. Okay, so neurogenic syncope accounts for less than 10% of the causes. Usually it will occur as a seizure or a migraine. If it is a seizure, even a vasovagal attack can have a seizure if it is a prolonged. Usually it is anoxia related, but there won't be abnormal movements or abnormal gaze. There won't be loss of bowel and bladder control in a vasovagal syncope. There won't be any tongue bite. And vasovagal, they will recover quickly. There won't be a prolonged postictal state. So if these pointers are there, you have to think of seizures as a cause of a syncope. But seizures, if it is a cause of a syncope, the child will have other abnormalities also. So summarizing the causes, in non-cardiac, usually neurogenic, vasovagal is the commonest, accounting for 80% of the cases, followed by situational orthostatic parts. If the history is very inconsistent, everybody is telling in a different way, you have to think of psychogenic pseudosyncope. And hypoglycemia, anemia, infections like systemic illness has to be thought of. Seizures, atonic and absence has to be thought, and trauma can be a cause of a syncopal attack. In adolescent females, pregnancy has to be thought of, pulmonary hypertension and embolism. Cardiac, I have already mentioned, drugs, beta blockers, vasodilating agents, sedatives, antihistamines, because we routinely use, that can cause a syncopal attack. Before 6 years of age, syncope is mostly caused by seizure disorder, breath holding spell, or a cardiac arrhythmia. So if a seizure occurs before 6 years of age, we have to analyze the history and look into further. So conditions that can mimic syncope: migraine, conversional disorder, hyperventilation, intentional strangulation, especially in adolescent, and narcolepsy. So syncope, how we proceed further, how to evaluate in all cases. So detailed history, what the time of occurrence, what the activity leaded to the syncope, associated symptoms, posture of the patient, and family history, especially it will give a clue towards cardiac cause. So description of the event either by the child or the bystander, if a video is there, it will have of much help. So preceding events, whether it is exercise associated, if it is aroused due to acute loud noise, it could be a long QT syndrome. Okay, postural change, already I have told you, it could be a orthostatic hypotension. Pain or emotion, it could be a vasovagal. Still, familial catecholaminergic polymorphic ventricular tachycardia, VT, will also be precipitated by pain or emotional stress. So past history, we have to look into congenital heart disease. If there is a developmental delay or perinatal history, atonic or absent seizures has to be thought of. Previous syncopal attacks, or if the baby is a diabetic, hypoglycemia could be a cause of a syncope. So some medications, substance abuse, now it is commonest now it is becoming common among the adolescents, so that illicit substance abuse has to be elicited. So family history, early cardiac death, sudden death, we have to ask them, single motor vehicle accident or drowning, known arrhythmias or familial cardiomyopathy. So on examination, it should be complete physical examination along with measuring BP in sitting as well as the standing posture, usually after 3 minutes, BP as well as pulse rate documentation. Cardiac and neurological, detailed neurological examination. In examination, vital signs, if it's bradycardia, then we look into the ECG to find out whether it is a heart block, atrial fibrillation or sinus node dysfunction. If the pulse volume is low, it could be because of left LVOT. BP, if it is low, we will think in postural hypotension. If it is high along with radiofemoral delay, it could be a coarctation of aorta. Saturation will point towards congenital heart disease. Cardiac, we have to auscultate for the murmurs and sounds. Neurological, especially we have to see for a focal neurological deficit, even eye deviations, especially during the seizures, or a neurocutaneous markers. So syncope primary workup is simple. Detailed personal history, family history along with our examination, and ECG is considered as a part of a syncopal evaluation if there is a pointers towards cardiac evaluation, cardiac syncope. So investigations like blood sugar, we can do if we have seen the patient at the time or even shortly. Later on, it may not give a clue. Serum electrolytes including calcium and magnesium have a low diagnostical, it's not recommended. CBC, if we suspect anemia, urine pregnancy test in case of adolescents if needed. ECG, as I told already, it's widely considered as an essential part of the syncope, though cardiac etiology accounts only for 1 to 5% of the cases. Despite its low diagnostic yield, we have to prevent a sudden death. So ECG is a must. So even if we don't have a ECG in our peripheral setup, if there are signs of these red flag signs, we have to go ahead with the ECG in syncopal attack. That is history not diagnostic of vasovagal and no prodrome, mid-exertional event, syncope triggered by a loud noise or a startle with an abnormal family cardiac examination and family history, or a new medication with potential cardiac side effects, we have to do a ECG. So what to look for ECG? Either for rhythm disturbances or for structural heart disease. See, sometimes if we order and get an ECG, ECG may show abnormality, but not significant. Significant findings, insignificant incidental findings may be seen in 10% of the ECGs. Only less than 1% is will account to the abnormal findings. So this is a tabulation. See, if it is a QT interval, if it is long or short, we have to consider. Okay, type 1 Brugada syndrome, delta wave, which is indicative of WBW syndrome, or signs of myocardial ischemia, polymorphic PVCs, third degree AV block. This is considered as abnormal. The child has to be referred to a cardiac consultation and treated immediately. So echo, any red flag findings in cardiac etiology only, we will go ahead with echo. All syncopal patient doesn't need an echo. Ambulatory ECG, only in patients with palpitation, frequent syncopal episodes, or exertional syncope. Exercise ECG, we need, if you are in suspicion of long QT syndrome, then go ahead with exercise ECG or exercise stress testing. So neuroimaging, it is not advised, recommended in a simple case of syncopal attack. It is of low diagnostic yield. Only if there is an altered mental status or a significant head injury, or findings raise the concern of a space occupying brain lesion or a seizure disorder, we will suggest a neuroimaging. EEG, again, if there is a prolonged loss of consciousness or seizure activity or a prolonged postictal phase, because epilepsy is a rare cause of syncope without any underlying developmental delay or a perinatal risk factor. Red flags in the evaluation, mainly, if you take home this message, I will be very happy. Syncope, especially during any activity, exercise or supine posture, or if it is not associated with prolonged standing, which will point towards vasovagal, or if it is preceded by a loud noise or extreme emotion, absence of pre-syncope, or if the syncope required a CPR or a injury, or if it is associated with injury with a positive family history, or there is a past history of Kawasaki disease or cardiac surgery, and abnormal examination as well as symptoms suggestive of cardiac etiology. Management, as soon during the pre-syncopal period, if we make the child lie down and elevate the leg, it will increase the preload. After the syncope, just a reassurance, advise them to increase their general oral intake, adequate sleep, regular exercise, and avoiding the triggers. So techniques like this will prevent the venous pulling if the child needs to stand for a prolonged period in the assembly. So like cross legs, squat, crossing of limbs. So medications only it is recommended in the refractory neuromuscular, neurally mediated syncopal attacks like vasovagal, fludrocortisone or midodrine. Orthostatic hypotension, gradual change in the posture rather than the sudden change with avoidance of medications and IV fluids. This is the last slide. See, this is the algorithm. If we follow this algorithm, we won't miss any etiology to diagnose the syncopal attack. If it is a prolonged LOC or postictal associated with headache, seizures, or focal neurological deficit, first rule out neuro. Okay. Then if it is an abnormal cardiac history with an examination finding or abnormal ECG, it could point towards structural or arrhythmias. Then look into the systemic ones. Followed by, if there are changes in the BP or heart rate changes, I mean the child assumes the upright posture, it could be orthostatic hypotension or POTS. Abnormal respiratory pattern, hyperventilation or a breath holding spell. If there is a clear precipitating factor with a trigger or a prodrome, it could be a vasovagal. If nothing is there, then only we can label it as a conversion disorder. So differentiation is usually possible by a detailed history, physical examination and basic investigation like ECG. Unnecessary investigation should be avoided. Thank you.
Thank you, ma'am. Thank you for an awakening session on syncope. Generally, we see patients coming with MRI and CT films for syncope. They themselves get it done. And you recommended not on neuroimaging. Yes, ma'am. Thank you, ma'am.
family history, if there is a sudden death in the family, it could point toward cardiac. Or if there is, see nowadays, parents themselves, they know they are a long QT syndrome or cardiomyopathy, children will have the genetic risk of getting the same. So family history, mainly we are thinking in terms cardiac. Migraine I have mentioned now. So if it is a migraine, neurologically you will have that findings. Migraine, you will have the family history.
I request Shanmugh Priya ma'am to hand over memento to Dr. Ram Kumar sir. Dr. Ram Kumar sir. Dr. Ram Kumar sir to hand over memento to Dr. Shanmugh Priya ma'am. Thank you, sir. Thank you, ma'am. Thank you, delegates. We are closing the session for today. Be present for banquet tonight.